This video will cover the definition, etiology, pathophysiology, clinical features, risk factors, evaluation, diagnosis, treatment, and complications of meningitis. Meningitis implies a serious infection or inflammation of the meninges. Bacterial meningitis can be fatal if not treated. The meninges are the three membranes, dura mater, arachnoid mater, and pia mater, that enclose the brain and spinal cord. Meningitis can be infectious, caused by bacteria, viruses, fungi, and sometimes parasites. It can also be non-infectious, resulting from autoimmune disorders, cancer, or drug reactions. Meningitis typically occurs through hematogenous seeding. Bacteria colonize the nasopharynx, enter the bloodstream, cross the blood-brain barrier, and cause an inflammatory reaction in the subarachnoid space. Another route is direct contiguous spread, where organisms enter the cerebrospinal fluid via neighboring structures like the middle ear or sinuses, foreign objects, or during operative procedures. Viruses can penetrate the CNS through neuronal pathways or hematogenous seeding. The pia arachnoid matter becomes congested and infiltrated with inflammatory cells, forming a thin layer of pus. This can lead to adhesions, obstructing CSF flow and causing hydrocephalus. Cranial nerve damage may also occur, and pneumococcal meningitis is often associated with high mortality. Meningitis presentation varies by age and immune status. Typical symptoms include fever, neck pain or stiffness, and photophobia. Other nonspecific symptoms are headache, confusion, irritability, and nausea or vomiting. Increased intracranial pressure signs indicate a poor prognosis. Inflammation of the meninges causes reflex spasm in paravertebral muscles, resulting in neck stiffness. Koenig's sign, where pain occurs upon extending the leg at the knee when the hip is flexed to 90 degrees, is due to hamstring muscle spasm. Brudzinski's sign is the spontaneous knee and hip flexion when neck flexion is attempted. Note that Koenig's and Brudzinski's signs are present in only about 50% of adult cases. A purpuric or petechial rash develops in about 50% of patients with meningococcemia, primarily on the extremities. Risk factors for meningitis include close contact exposures, incomplete vaccinations, and immunosuppression. Children younger than 5 years and adults older than 65 years are also at risk, as are those with alcohol use disorder, bacterial endocarditis, malignancy, dural defects, and IV drug use. Meningitis is diagnosed through cerebrospinal fluid analysis. Specific tests include PCR for viral, culture for fungal, and smear and culture for mycobacterial meningitis. Ideally, CSF is obtained before antimicrobials, but antibiotics should be started first if bacterial meningitis is strongly suspected and the patient is severely ill. CSF findings in bacterial meningitis from a lumbar puncture include elevated opening pressure and increased leukocyte count. Protein concentration is elevated, often above 150 milligrams per deciliter, due to blood-brain barrier disruption and protein generation by cells and microorganisms. There is a low glucose concentration, typically below 40 milligrams per deciliter. A gram stain of CSF identifies the etiological agent in 60 to 90% of bacterial meningitis cases. CSF PCR may aid diagnosis. Prior antibiotic therapy reduces gram stain and culture yield, but other values remain unchanged for several days. The necessity of a head CT before lumbar puncture is debated, especially regarding the risk of brain herniation in patients with increased intracranial pressure due to acute bacterial meningitis. Blood work should include blood culture and serum electrolytes. Treatment for bacterial meningitis includes critical supportive care and antibiotics. Management involves maintaining the airway, oxygenation, sufficient intravenous fluids, and fever control. Empiric therapy for neonates up to 1 month old includes ampicillin, cefotaxime or equivalent, and acyclovir, all intravenously. For patients older than 1 month, treatment includes ampicillin IV and ceftriaxone IV. Adults from 18 to 49 years old receive ceftriaxone IV and vancomycin IV. For adults older than 50 and the immunocompromised, the regimen is ceftriaxone IV, vancomycin IV, and ampicillin IV. Steroid therapy has been reported to reduce mortality in Streptococcus pneumonia meningitis, but not in Haemophilus influenzae or Neisseria meningitidis meningitis. For meningitis associated with a foreign body, the treatment includes cefepime, ceftazidime or meropenem, and vancomycin, all intravenously. If the patient has a severe penicillin allergy, moxifloxacin IV and vancomycin IV are used. Fungal or cryptococcal meningitis is treated with amphotericin BIV and flucytosine by mouth. If clinical signs of increased intracranial pressure develop, interventions to maintain cerebral perfusion include elevating the head of the bed to 30 degrees, inducing mild hyperventilation in intubated patients, and using osmotic diuretics like mannitol or saline. Chemoprophylaxis is indicated for close contacts of patients diagnosed with N. meningitis and H. influenzae type B meningitis. This includes housemates and healthcare providers in proximity to secretions. Antibiotic chemoprophylaxis for N. meningitis involves rifampin, ciprofloxacin or ceftriaxone, and rifampin for H. influenzae type B. Differential diagnoses for meningitis include stroke, subdural hematoma, subarachnoid hemorrhage, metastatic brain disease, and brain abscess, which might also coexist with meningitis. The most common complications and sequelae include hearing loss, behavioral and cognitive difficulties, motor deficits, seizure disorder, and visual impairment. Other complications are cytotoxicity from immune elements, hydrocephalus, and cerebrovascular complications. These references were used to create this video. Do you have any questions about the material presented in this video? Thank you for watching this video on meningitis.